Joyce Tang. I'm a nurse at UCSF Medical Center. I've been doing head and neck radiation almost 20 years there, and I'm very happy to be here today. Just a session outline for today, orientation to head and neck cancer patients, mainly talking about the side effects with the radiation, special considerations for the different head and neck site diseases or disease sites, the very important psychosocial care of these patients, and then just some final pearls. This is just we're going to brief overview of the numbers, the risk factors, anatomy, and then again, how the different sites affect the side effects. Go to the neck. Okay. Yeah, what you should know about head and neck cancer patients. Obviously, they come from a wide variety of populations. I try to keep the education simple and straightforward for them. They often have to meet with a variety of doctors and have met many appointments before they even start the radiation, so they're very overwhelmed. It used to be many of the patients were older in population, but as the HPV or human papillovirus has become more prevalent, we are definitely seeing younger populations of these patients. Used to be very much smoking and drinking caused most of these cancers, and it still can. So, smoking cessation is always very important to talk about with our patients. And then just an overview to let them know that it takes a long time to heal from this process. So, the treatment may be 6.5 weeks, but it takes several months for many of their side effects to improve. Like we talked about, a lot of the cancers are related to tobacco. So we have our own like cessation program. We keep trying different ways to get through to these patients. Many patients do literally quit cold turkey when they get diagnosed, which is great. It's very hard to do. But many are always like, I'm just having a puff or two. And it's really hard to quit. And I really commend them a lot when they're able to. Alcohol, in general, it is still more of a male-dominated diagnosis. A lot of these numbers are for the states, so may not apply to obviously the global community. But in the US, it is more Black and white populations more than Asian or Hispanic. But obviously, we treat a variety of patients. A lot of environmental factors. We ask patients if they're painters, if they're around asbestos, the tar, even bakers breathing in flour all day, chemicals. So we ask when they do the history and physical, we ask what are the possible reasons for getting their cancer. Poor nutrition, just in general, poor oral hygiene, gastric reflux, just sometimes having that acid keep coming up into their throat or mouth. And then, like I talked about, HPV viral infection is really starting to dominate a lot of our cancer care. And they do luckily respond better to the treatments. So, a big proponent of how many side effects the patient are going to get or what side effects they're going to have is where their actual tumor is found. So, there's a variety of places that we treat: the sinuses, the parasinuses, the nasal cavity, the oral cavity, which can be the tongue, the floor of the mouth, the bones of the mouth, the mandible and maxilla. Nasopharynx is a big population for us, the oropharynx with the tonsils. A lot of the hardest treatments are the hypopharynx. They just don't do as well. We see a large variety of the salivary glands, larynx, that's just, we don't see the trachea. And then the esophagus typically is there and it's a big part of us, but typically that goes to the GI team. So obviously not all of the head and neck cancers are treated the same, and the side effects depend on where they're being treated. If they're getting concurrent chemotherapy, it can make things harder, of course. And then depending on which lymph nodes we're treating in the neck can also make their treatment much harder. If we're doing, so the nasopharynx plan, almost always, unless it's a very small stage 1, which we have treated a few of those, but by and large, because the nasopharynx will drain into both sides of the lymph nodes on the neck, we often treat the lymph nodes, and you can see this is the plan. So we treat all the way from the nasopharynx near the base of skull all the way down to the clavicle to cover all the possible places the cancer can move to next. This plan seems, yeah, we're treating a large side of one of the sides of their tumor there. And just be aware with nasopharynx, a lot of the times they come with advanced stages and the cranial nerves are involved. So they'll have facial droop, they have numbness on that side. It can really affect their vision. A lot of times they start coming in because if they're noticing double vision or their extraocular eye movements are affected. The facial droop can affect their mouth, so they're biting their tongue. So it has a lot of issues if once the cranial nerves are involved. This is a treatment plan for a base of tongue patient. So lower stages, obviously we can just treat one side. Typically we treat the side that's affected and then a lighter dose on the contralateral side. But you can imagine that you definitely get a sore throat if we're treating one side, but it's much worse when we're treating both sides of the tongue, both sides of the throat. We also treat, sometimes it's just in the larynx or the vocal cords. So the treatment area is much smaller. It's just really focused right on the larynx. So they mostly just have vocal issues and they do get a sore throat, but they don't get a lot of the dry mouth and the taste changes that many of the patients where we treat the oral cavity have. All right, so we'll get into these side effects. This is obviously a myriad number of things patients can get. So we'll start with, you can see the list here, and we'll just start with the anxiety because radiation itself, treatment isn't causing the anxiety. Obviously, it's a lot of patients are claustrophobic. They've had some post-traumatic stress where they've been in confined spaces or, yeah, so they need some kind of medication to get them through. We typically use Ativan here, but some patients have used Xanax in the past, so they know that works for them. But typically we try to give it 30 minutes before they make the mask. You can see the mask here, the photo. So they are pretty tight in there. They're pinned to the table. The mask covers their whole head and neck, down to their shoulders. They're given like a horn in case they're having issues and want the treatment to stop or they need to get up. They also have things in their mouth, moving their tongue out of the way, or mouth guards covering their teeth. So it's hard to have all those things and breathe. So a lot of patients, it's just a lot for them to handle. Although a lot of patients do get used to it. So the first week or so, they need the medication, but as they get used to the treatment, they can use either some deep breathing or we play music during the treatment. So patients can choose what they like. And obviously, if you have something that pleases you or brings you joy, it's a little easier to manage. Mucositis is the painful sores that develop in your mouth or throat, depending on the treatment field. Up front, we have patients rinse their mouth with salt and baking soda rinses. We try to tell them to use kosher salt or sea salt if they have it, or the non-iodized salt can just be a little less stinging to them. We do a one-to-one combination for the salt and baking soda. We tell them to add that to about a quart or liter or 4 cups of water and to make sure that they rinse and spit that out. We try to tell them to do it multiple times a day, either after they're eating, especially when they wake up. Most patients feel the most dry at night, so they wake up and really like to do the rinses. In the beginning, it's definitely a chore to remember to do something 5 times a day. So sometimes they'll put little notes on the mirror or have their phone go off, just reminders to do it. And we do tell them to start this the first day of treatment. Many patients think it's not till they start feeling something, but it really is preventative to keep the mouth clean. The baking soda helps. The radiation really alters the pH of your mouth, so you tend to get a lot of it. That's why you get the yeast infections and things, so it really keeps it moist and clean. When the sores start, which is typically with radiation, the side effects don't start immediately. You have a little bit of a delay. So typically the mucositis is third week of the 6-week treatment. And we usually start with giving them a viscous lidocaine solution. The doctor has to prescribe that to the pharmacy. And it's usually a teaspoon, and they can use it up to 8 to 10 times a day. There used to be issues with worrying about the lidocaine in your cardiac, but I've never really seen an issue. So we really tell them that they can use it even throughout the meal as they're eating. It does wash off as you eat, so it doesn't last that long. And if it's throat pain, they need to swallow it A lot of we fill the prescription and we say swish and swallow, but the pharmacist will tell them to spit it out. It has to touch where it hurts to work. That's just the way that's just how it works. So they have to swallow it if it's their throat. Sometimes the mucositis is on the side of their tongue or in a spot on their cheek, so it's not all through their mouth, and they don't like that feeling of their whole mouth being numb. So we give them dental rolls or cotton swabs, and they can just hold it there where it hurts, especially if it's between like their tooth, their teeth and the cheek, or like I said, between the tongue and the teeth. They can hold it there with it soaked in the lidocaine. Our dietitian will often recommend these L-glutamine rinses, which it's a powder that you mix with water and it helps keep the mouth clean as well for healing. We also use Manuka honey because it can be healing and a little moisturizing for them when it hurts. Beyond the lidocaine, because I said it's really transient and washes off as you're eating, then we move on to Tylenol, ibuprofen, or acetaminophen, ibuprofen, and then move up to opioids. A lot of times it hurts a lot to eat, obviously, so pills are even difficult to swallow. So we'll do pain patches or try to do more like smaller pills, but long acting. Again, you can go to the next slide. So I try to get some pictures. This is the World Health Organization grading system. So you can see this is just showing the front of the mouth, a little bit of the tongue, but it does actually occur anywhere that the radiation's going. So if we're doing the tonsil or the base of the tongue, it's on their soft palate and down their throat. But grade 1 is just a little bit soreness. It can be like a bright red color. The next, they start getting a little bit more of the breakdown where they can still swallow, but it is starting to get painful. And then the ulcerations are where it's much more extensive, they're a little bit deeper, and that's when they're really having trouble swallowing food. And the 3 and 4 are much more severe. And then you can see how much that would hurt to have the side of your tongue have those sores and it rubs against your teeth. So as you're trying to chew and swallow, it really hurts.
And Parag, I was wondering if you might be able to speak from the clinician perspective. Why is it important to grade the mucositis? And how is that helpful if your nurses come to you with an assessment?
Sorry. Thank you, Ben, for asking that question. Joyce, what an important topic. I think that mucositis is something that we monitor very closely. So one of the things, as patients progress from grade 2 to grade 3, you really need to start thinking of oral supplementation, which can, in terms of nutritional intake. So one of the things we start then thinking about when patients get grade 3 mucositis is, do they need a feeding tube to get their nutrition in? The other thing also, I would say that oftentimes you can really support grade 2 patients with supplemental IV fluids if they don't have a feeding tube. And you can carry them through treatment without the need for a feeding tube if they're getting good hydration and then good nutritional counseling for supplementing that with some calories.
Okay, the next is the xerostomia, which is just the dryness of the mouth. When we're treating the salivary gland, obviously you get dry, but when we treat the lymph nodes in the neck, there's many more salivary glands in your throat than you think about. So they do get very dry from this. It is one of the first side effects they notice. They really say it's like a sticky, their mouth feels like paste is often the word they use. It's one of the first to come, but it's actually one of the last to recover. We tell them it can take up to a year or two to be like what their probably normal is going to be going forward. Most of it does come back within the first few months, but often patients say it's never 100% normal again. The dry mouth attributes to a lot of the yeast infections or the thrush, and they often have lifelong dental issues because it's your saliva that protects your teeth. So they really need to keep their mouth moist. What we do during treatment is just recommend a lot of over-the-counter products with either xylitol. A lot of these are available without the prescription. I know not all. I didn't want to use a lot of brand names because I don't know what's available everywhere, but we have a company called Biotine and they have rinses and gels and sprays and gums and all kinds of things if you go to that section of the pharmacy. There are saliva substitutes. We really like this product called Xylee Melts, which are little lozenges you tuck above your incisors, and you can actually put them in at night because, like I said, a lot of patients feel the most dry at night. You breathe through your mouth. Sometimes they're hard to find, so we have them order it online, but they do provide a lot of relief. Obviously, they don't work for everyone, but we find it very helpful and patients tend to really like them. If they're going to do suck on candies or something for relief of the dry mouth, we try to have them be sugar free because we don't want a lot of sugar sitting on their teeth when they're already prone to calories or dental caries. A lot of people like lemon or the tart kind of gives them some relief from because it makes you salivate. Otherwise, there are prescriptions available, pilocarpine or cevimeline, which patients do, but just be aware that it makes all your glands produce. So it's not just you get moisture in your mouth, but you tend to sweat or have issues like that. Some patients don't like that feeling, but it can give them some relief if they are very dry. I used to order a lot more of these other products, Saliva Max or Nutrisal. They're usually from specialty pharmacies and it's not covered and it can be very expensive. So I've tend to stop ordering from them because they keep changing pharmacies and it's hard to figure out who's actually using it anymore. Sometimes they'll send them samples, but like I said, it hasn't been as much on my radar anymore. And then recently, the most new thing is that the surgeons, our head and neck surgeons, can actually move their salivary gland if they're getting treatment on both sides of the neck out of the way so that it really helps protect that. So we're not going to radiate that where it's moved to protect the salivary gland. And it does help keep them more moist through their lifetime. They don't move it back after it stays there.
Yeah, this is such an important side effect, and a lot of our patients have it. Parag, could you share with us what your some tips that you may have in your clinical practice with your patients?
Yeah, no, I think Joyce really hit exactly the kind of key points. I still think that salt, baking soda, and water gargles work the best. It is the cheapest, it is the most effective. And I think certainly using some of these other products like biotin, Zalamelts, something that we use routinely. I would agree with Joyce that pilocarpine is really challenging to add during the course of chemoradiation because it has its own set of side effects and patients are already complaining of really bad taste during chemoradiation, and the pilocarpine really compounds that. So I'm not a big fan of pilocarpine during radiation. Sometimes I will certainly use pilocarpine in that first couple of years after radiation if you need patients with significant dry mouth. Some of these other commercial products are exquisitely expensive. Joyce hit it on the mark. They're really not affordable for the vast majority of our head and neck cancer patients, even here in the US. And so we typically don't do that. I find the surgical transfer of a submandibular gland very helpful because one of the things about head and neck cancer is that while modern radiotherapy does such a good job of sparing at least one parotid gland, your parotid gland really only produces secretory saliva. It does not produce any resting saliva. And for the vast majority of patients, unless you're able to surgically transfer that submandibular gland outside of the radiation field, if you're treating lymph nodes on both sides of the neck, you are essentially obliterating their submandibular gland. So even if you can spare their secretory saliva with a good radiation plan, you're not really sparing their resting saliva long term. So to me, that's probably the most effective way of sparing long-term salivary function is that gland transposition. Obviously, not every patient is a candidate for that. And certainly you need a willing surgeon who is technically skilled in doing that gland transfer.
A huge part of them being dry and, like I said, altering the pH balance of their mouth is them getting yeast infections. It could be called thrush, oral candida. Sometimes they show up like this where it's just very easy to diagnose and it shows up as these little white kind of dots. We call it cottage cheese appearing. So at that point, we either start with a nystatin rinse or the antifungal like fluconazole. Sometimes we do it for a week or 2 weeks. The nystatin is easier. They can rinse. The pill is easier. You could take it once a day. The nystatin is a rinse and it has to be like 4 times a day. So they're already rinsing with the salt and soda. A lot of times the dental people give them another rinse if they're doing the glutamine and they get so confused. What comes first? What second? So we try to do the fluconazole, but it does metabolize through your liver. So we always check their LFTs before we start it. And then the next photo kind of shows, sometimes it's shows up more as like a coating on your tongue. If you could advance the slide. So a lot of times it's like, I'm looking, the resident's looking, the attending's looking, do you think it's yeast? Is it not yeast? Sometimes we just put them on something prophylactically. They can even do the fluconazole just for 3 days and see if it helps. Oftentimes it's literally, they're like, I don't know, all of a sudden the pain came out of nowhere. It's a stinging pain. It's too early to have really mucositis, or we don't see mucositis. So we always want to check for the yeast infection. A lot of patients are just more prone to it. If some women get it vaginally a lot, or you can get it anywhere in your skin folds and stuff, they are just more prone. So some people really need to be on the fluconazole the whole 6 weeks and even continue after for a while. So it can be a little bit just adding on to another thing that's going on in their mouth. Okay, the real problem for patients is when they cannot taste food. So as you can see, we can manage pain a little bit. We can help with the dry mouth a little bit. There are products. Taste is one of the things we haven't really come up with a great solution. And it's a range. The things people say things taste like, how do you even know what people have probably maybe can imagine what cardboard tastes like, but it can be very metallic. It can be bitter, a lot of times garbage, sewage, sawdust, and a range of things that I hear people say it tastes like is horrible. Like I said, we just have the least amount of offerings. Oftentimes we say if it's the metallic taste, which can be from the radiation, a lot of times it's more from the chemo, but to change to like plastic or bamboo utensils, reducing red meats. There's things called like Mediquil that patients don't say it always helps, but same thing, that's when they can suck on candies and things. Sometimes we recommend doses of zinc. I think it was researched and did show to be helpful. I don't think our patients have noticed it being that helpful, but if they're really complaining about it, we will recommend that. This is when I really have to say food is medicine and you have to eat even if you can't taste it. And it's really hard because they keep adding more salt to things, they'll keep adding more sugar to things. And sometimes it's not all like everything is bad. They could get glimpses of food, or they can taste sweet but not salty. It is different for everyone, but this is when they really struggle. Like I said, usually they can add more herbs. We try not to obviously have them put things with salt because the family members all think things taste great and they're like, this tastes terrible. And it's always hard for the cook in the house to hear that their food is not good. Right now we have clinical trial going on with something called miracle berries. It's still ongoing, so the results aren't out. It mostly makes food taste sweeter, but I don't think we'll have to see what the research shows. I don't know if it's going to be the most positive trial, but Parag, do you have any other things you tell your patients for taste?
No, exactly, Joyce. Food is medicine. This is the number 1, 2, and 3 message I say during the consult and every week of treatment, that you really can't think of food as for leisure or taste. It is something that you have to schedule. One of the things I'll always tell patients is think of this being when if you've had kids at home, how you feed your infants. It has to be scheduled. You have to put this on a calendar and plan to eat usually 4 to 6 meals a day, and because meals are just going to be much smaller. Dysgeusia, this taste changes is one of the hardest things I think our patients go through, and this really varies in terms of recovery depending on where your tumor is. So particularly oropharynx patients, if they have a tonsil tumor or a base of tongue tumor, your circumvallate papillae, which are your taste buds, are completely in the radiation field, which is very hard to spare. So for those patients, taste recovery can take 1 to 2 years. But fortunately, vast majority of our other head and neck cancer patients really recover most of their taste within the first 6 months post-treatment.
Thank you.
Yeah, I'm
I
glad to
think
hear it. It's universal that this is one of the harder things.
we have a question in the chat. I think you answered one of them, Parag. The taste changes if they're permanent or if they improve post-radiation, and you're counseling with the patients around that. The other question is, what's better to use, nasogastric tube or G-tube for feeding?
Yeah, generally, I think if your patients are going to need sustained nutritional support, you really need a G-tube. NG tubes, as you can imagine, you're already making these patients very uncomfortable by directing all that radiation to their head and neck. And so then having another thing going down your very irritated pharynx is not something that you can sustain long term. So I always think of NG tubes as a very short-term solution on the order of days to a week while you're waiting for that G-tube to be placed in most patients. And then I saw a question about mucositis on the lip. So the most important thing that you can do to spare mucositis on the lip is work with your radiation oncologist and your physics team to spare the lips. I think this is one of the things that we used to see a lot in the early days of IMRT-based planning, where there was a lot of entrance and exit dose going through the anterior mouth, where patients would get a lot of lip mucositis. Fortunately, we don't see that for most patients, unless obviously you're treating an oral cavity patient, then you're going to get a lot of lip mucositis. Joyce mentioned using lidocaine. I think lidocaine works really well. There are topical sprays of benzocaine available that are in most countries over the counter. In the US and Canada, you have the spray called Hurricane, which you can get, and they come in many different flavors. And it's just a topical spray that patients can apply as frequently as they want to help numb that mucositis on the lip. Last thing I think that really helps, Joyce mentioned a lot of different medications that we use. One I think that really works well on mucositis is a medication called gabapentin, which is a neuropathic medication for pain that we routinely now more and more use in our head and neck cancer patients. There are two schools of thought. There's one school of thought, very similar to what Joyce talked about. You start those salt, baking soda, and water gargles on day one, not when your symptoms arise. So there are people who think about using gabapentin the same way, that you start people on gabapentin on day one of radiotherapy, and then there are these dose escalation handouts that are available for patients that you can use. And there are others who say you start gabapentin once patients start developing grade 1 mucositis, and then do that. I think that works really well. I saw in the chat magic mouthwash, so I would say beyond salt, baking soda, and water gargles, that is my number 2 favorite thing in head and neck cancer patients, is magic mouthwash, which is basically a mixture of Benadryl, lidocaine, and Maalox. So yeah, we prescribe that by the gallons, and I'm sure Dr. Malik and Joyce do the same thing. We prescribe magic mouthwash routinely.
All day. Okay, shall we move on to the next slide?
I have a few things just from the chat. So yes, magic
yes.
mouthwash. We have a lot of pharmacies, they don't like compounding. I guess there's a lot more regulatory issues that they have if they compound at their pharmacies. So we have a pharmacy across the street from our hospital that we often just send a lot of patients to, because we know they'll make it and they have it. In the community, it's very hard to find compounding. So we often start with plain lidocaine, but yeah, it doesn't taste that great. Adding the Benadryl kind of cherry flavor helps. So we try to do the mixture if we can. NG versus PEG, like he said, it's very short term to do an NG. I put them in clinic so it can be done within a few hours, and they have nutrition that night or starting that night. PEG, the G tubes for us require interventional radiology. It takes 2 weeks to schedule. They stay 1 or 2 nights in the hospital, which interrupts their care. So we know up front, like if it's hypopharynx or something, total laryngectomy, we know they're going to have difficulty. We try to put it in up front, but during the treatment, it's a little disruptive, although much more better for the patient not having this tube hang out of their mouth. It's much more permanent. But if we're just doing those few last weeks of treatment and maybe a month after, we try to do the NG short term. All right, so the dysphagia, same. It's from the mucositis. It's going down their throat sometimes. When we do our weekly on-treatment visits, we get their weight, obviously. If it's 5 pounds or more that they've lost, we make sure they're not dehydrated. We do orthostatic vital signs. That's typically the first thing, is they're just not drinking enough. And like I said, we try to get them into the infusion center so that if they're getting chemo once a week, we just add on a couple more times. Sometimes they literally go every day, even on the weekends, if they really can't keep up with the amount of hydration that they need. If they're not getting chemo, then our doctors prescribe it, and we do the authorization and get it that way. But if they're getting chemo, they're already set up in the system. We consider the feeding tube once they hit 10% of weight loss. So we're okay with a couple pounds a week. Believe me, every patient says they want to lose weight. I want to get back to my high school fighting weight. We all want to lose weight, but if it's too big of drops, the mask starts fitting differently, the radiation's going to the wrong place, we have to replan them. So we have to stress the importance of eating, because like I said, if they're moving away from mask, the skin gets harder hit. They're not healing. They need the protein for your body to heal. You have to get the nutrition in. We have them meet with our dietitian once a week. She actually works in our department every Friday. So she doesn't have to meet with the patients every week, usually in the beginning, to get a calorie count and a protein count up front. And then as they're struggling, meets with them to give them tips and tricks to get through. Obviously, they move to soft food, shakes, smoothies, high calorie supplements. We stress protein, and a lot of patients go and get protein, the supplemental protein drinks, but just be aware those have a lot less calories. They'll have 150 calories in 8 ounces, but a lot like 60 grams of protein. Whereas if you get the ones that are like Ensure or Boost Plus or whatever product you have that has like more calories, you can get almost 350 to 480 in 8 ounces. So if you're just trying to get down the calories, the bang for their buck is to try to get the ones that are not just protein, high in protein. We have a team of speech language pathologists who see our patients. We try to have them see them before, during, and after just to help them. Sometimes it's that they're aspirating or having issues depending on where the cancer is. So they do give them a lot of like tongue exercises and throat exercises to help with them. And they'll often do this FEES procedure where they actually put a scope down there and have the patient swallow and see where the food's going to decrease that aspiration risk.
Joyce, I have a question. If a
Mhm.
patient asks you with a percutaneous gastrostomy tube, how long am I going to need this for? How would you counsel them on that?
If they're going to get the tube, we usually say it's 2 to 3 months, and they have to be eating half of their calories orally before we'll consider taking it out. But it can be even longer, but typically a few months.
And the other thing I would say is that if you have the luxury of having a speech language pathologist in your head and neck program, I think that they are probably one of the best partners post radiation to help you determine when the feeding tube can come out, because what they'll actually do is careful swallowing function tests as patients are recovering from their radiation and ensure to tell you that the patients are swallowing safely. Because one of the things that you worry about once you get significant dysphagia is that if you're altering their swallowing mechanism, then unfortunately, even when patients are taking oral intake, that food is ending up in their lungs with the risk for an aspiration pneumonia over. And so you want to make sure that they're safely recovering before you take that feeding tube out. So I think that partnership, if you are able to have one, is really important.
Yeah, some patients want it out as soon as possible. Others, I think, hang on to it a little too long, and they really do need to start swallowing. We even tell them to swallow when they have the tubes in. They need to keep it's a muscle like anything else. They need those muscles functioning. So even if it's just sipping on a little water, obviously, if it's safe, we do still encourage them to eat. All right, yes, the thickens secretions. This kind of has to do with the dry mouth as well, but this is very problematic. A lot of patients are just producing a ton of mucus in their mouth. They literally carry around little spittoons or either the little emesis bags or a cup or jars. It's really nasty at times, but I feel bad. They're just in the middle of you're talking to them like, sorry, I have to go spit. It can cause nausea if they're swallowing it. It has a bad taste in their mouth. So we try to thin the secretions. It doesn't make it less, but it makes it thinner so they can expectorate it easier. A lot of times we order oral suction at home if that's available. Can also be difficult with some of the home care companies, but an insurance covering it. But it is they can just use the yank hour oral and suck that out instead of having that, because the constant that expectorating of having that it's damaging to your throat, like because they start having like blood streaks and stuff between the mucositis and then that trauma from coughing it up. The hydration also helps with this, like Parag mentioned earlier, but the hydration helps thin it as well. Like I said, some can go actually every day. I haven't heard people doing the meat tenderizer as much. Some people find bubbly water helps break it up. Papaya is actually known, but I think you have to do it in high amounts. So either the fruit or you can take the supplements. But these are just things when we're really more desperate to help these patients. Does anyone else have better ideas for this? Because this really is when people struggle as well. It sounds like there's not much else to do. All right, next slide. All right, the skin reaction. So this is a few weeks into treatment as well, but we try to prevent it from getting too bad. So because it often, even though there's a delay in the beginning, the peak radiation reaction to the skin can occur the last 2 weeks, we say to the 2 weeks after. So we keep having them, we do really take a close look at their skin. We give a product called calendula. It's a flower-based plant with like magnolia flowers or any doctor-approved emollient lotion. We often, if they have many patients, my fan went through cancer and used this lotion, they swear by it. So we make sure they bring it in. We look at the ingredients and it's nothing too harmful. A lot of times it's just herbs and things, which are fine. But we do want it up front, day one. We're trying to prevent this from getting too bad. We have them, and same thing, patients, oh, I thought you meant when it starts to get red. So we ask them every week, are you putting your lotion on? And starting the first day. Washing with gentle soap, try not to scratch or scrub, electric razor if they have one. Many patients don't, but they'll get one, or they'll just really be careful. The skin, once it has radiation reaction, is just not going to heal as well, so we don't want to have nicks or abrasions in there. Once it gets to be more grade 2 or 3, we move up to more ointments like Aquaphor. We recently started using vitamin A and D. Just be aware those are very greasy, so patients often don't like that feeling. We'll tell them to use it more at night, and they can use the calendula or whatever during the day, but lotion never hurt anything. So the more the better. The thing is, we ask them not to put it on a few hours before radiation. You just don't want, and it has to be a very thick layer to affect the radiation. But some patients do think, oh, put it on right before the beam starts, and we don't want that. So we don't tell them to wash it off or scrub it off, but just make sure it's well absorbed into your skin. The calendula is a cream, so it is very well absorbed. The ointments are a little bit thicker, so we don't want those sitting on the skin during the radiation. So some patients literally carry it with them and put it on right after when they start feeling really dry. Sometimes cool compresses, we don't want obviously any ice burns, but something cool can help bring down that sunburn feeling. And many patients, we all grew up putting aloe vera gel on sunburns. All the studies have shown that it's the one thing that doesn't really help. There's a lot of skincare research, and it doesn't really say one thing is better than the other, except the aloe vera is not great. And then they'll say, oh, but I have the plant. But that can have some, not bacteria, but if they're outside, so you don't want to use those either. The Skintegrity gel is just any kind of cooling gel can help. Once the skin starts getting dry or cracked, we move on to Meta Honey, which is usually Manuka honey that is sterilized. So we're not putting on honey from your cupboard. You want it sterilized because we are putting it on sometimes a little bit of broken skin, but it's antimicrobial and it helps provide moisture. Once it's grade 3 or moist, we move on to silver products. We have a gel that can be more topical, but once it's actually having a lot of exudate, we do use like dressings that have it impregnated in there that help put in the antimicrobial properties and absorb the exudate. If it's itchy, we'll use hydrocortisone, or sometimes we move up to memetazone, which is a prescription. Sarna has that menthol, but it can help with the itchiness. Sometimes there's clotrimazole for yeast on the skin. I don't see that as much. And then our breast patients, I know you had breast, I think last week, but they use a film to put on, and it helps protect or keep the moisture in. And it's great for breast because it's usually a flatter surface. And obviously it's tricky to put on a breast sometimes, but the head and neck, I've just tried multiple times, and as they turn their neck, it just doesn't stay on. So unfortunately, it's not really helpful for our patients. And then, like I said, because the skin reaction peaks at the end, I see them once a week until their skin is healed.
So this is one thing where everyone's practice is very different around the world. What have you tried, Parag, in your practice?
So I am a big fan of calendula. We used to routinely use a lot of calendula and still do. A couple other things that I think of. So I think you talked about hydrocortisone, 1% cream there. Initially there was a trial in breast cancer patients showing that mometasone, another topical prescription steroid cream, decreased the degree of radiodermatitis in breast cancer patients. This has now been proven also in head and neck cancer. There's a randomized trial looking at mometasone in patients with head and neck cancer. So now we actually, much like the salt, baking soda, and water gargle, start mometasone on day 1. In breast cancer, the instructions were to apply twice a day. Head and neck cancer patients have way too much going on to remember to do this twice a day. So I'll typically tell the patients just do this once a day, every day after treatment. So I'll typically start with hydrocortisone cream. And then I recommend if they want to you just need a very thin layer of that mometasone cream. So then I'll say you can supplement that with calendula or Aquaphor. Those are probably my 2 other favorite products. Definitely cheap and effective. And then as you start getting, again, I would say advanced grade 2 desquamation, grade 3 desquamation, then you're going to add things like Skin Integrity Gel, or you can use Silvadene, the cream that we use for burns, which actually works quite well. You can do soaks with, I see somebody in the chat just put in some saline soaks. You can do some soaks as well to keep that area clean. And then there are these Mepitel, these biolayered gel products that are available. I agree with Joyce. They are really hard to apply on the head and neck. You have to actually then, our nurses will actually cut them into customized pieces for the patients to be able to apply on the
Arts
area
and
that has,
crafts.
yes, that has significant desquamation, but it actually works really well. So I think that all of these things come into play. Skincare is also, yeah, I would agree, it's such a big part of the patient's journey. Luckily, this heals the fastest. So the one thing you can assure the patient is that their radiodermatitis will actually heal very well, generally within 4 to 8 weeks after treatment. So you can reassure them this is a very short-term side effect.
And Joyce,
Sometimes, okay.
Since this is so common and so important, can you speak about how you see them once a week until healed? You know, what that means is even after they finish radiation treatment, their skin is still like needing help, and it could even be getting worse the week after. So you will often see them after they finish treatment.
Yeah, so typically if they're needing a dressing during treatment, a nurse or I will just see them every day to put it on. Sometimes they feel comfortable enough to do it at home or the family member can do it. Definitely on the weekend, they're doing it themselves, the family member or the patient. So they do have to learn how to do it. So usually I try to see them once a week. Typically it only takes 2 weeks, hopefully. Obviously, the more extensive, if it's a skin cancer, we're treating the skin, so it is going to be longer to heal. But yeah, they said it is luckily the first thing to heal. But sometimes they live far away, and I have to just give them a bunch of dressings and say if it looks like this, or send pictures on the electronic record. Or they don't want to. Our patients come from 5 hours away sometimes, and once they go home after treatment, they don't want to come back. So I try to do as much management as I can. The other thing, sometimes they get an early folliculitis where it's just all their hair follicles are inflamed. So we'll use like Hibiclens, which is very harsh. So we just say a small amount, just twice a week to clean that top layer off, which can be
Yeah, I think
helpful.
that one of the thing that I will say is that there is sometimes a synergy between the choice of chemotherapy medication that you're giving and radiation, particularly if you're in a place that uses a lot of cetuximab, which can really compound the skin reaction for those patients. So if you're using cetuximab, typically you want to start those patients both on a topical antibiotic cream that they add to their skincare regimen. And oftentimes the medical oncologist will also put them on oral doxycycline because they get so much desquamation, as Joyce was mentioning, that folliculitis can very quickly become a superficial skin cellulitis for these patients and can be really difficult to manage. And so just be mindful of that as well.
Yeah, if their skin is sometimes it's just too red or has so much exudate and the silver products are enough, we do put them on an oral antibiotic. It's usually Keflex, which is another thing that's 4 times a day, but it is the most helpful up front. And it does help things heal much faster. So I don't know, we don't like using antibiotics a lot or overusing them a lot, but it does help in this situation. I think I put some photos up. Yeah. So the right is like just a brisk erythema. You can see the biggest problem for patients is on their supraclavicular, which is why I really stress you have to put the lotion much further down than you think. And when they're turning their head, it's where everyone's collars of their shirt fit. So we literally tell them get old t-shirts, cut them out, or wear wide V-necks or boat neck collars to prevent that friction. If it's starting to get, sometimes we'll just put those like Mepilex pads there to prevent that friction. And then the one is starting to break down. You can see the kind of crusting that's forming. And this is when they require more of the silver dressing. And yeah, it's a lot to keep on. We often have to wrap their neck. We don't want tape on the skin that's being radiated. They'll literally pull this top layer of their skin off. So we have to come up with all kind of nettings and things to keep it in place. And then just be aware, sometimes the skin doesn't heal as well. So this is a pretty bad reaction in A. It's pretty deep, the reaction. And then even when it healed, it has this appearing. And just be aware if you're darker skin, the scarring can be worse. Sometimes we've used some kind of, I think there's silicone strips that help with scarring if patients are really worried, but typically it doesn't heal like this, but just be aware it can be a long-term site that patients have on their skin. All right, hair loss. We usually only use hair. It's focal where the treatment field is. Obviously, we're treating the neck. So for men with beards, their hair starts falling out on their neck. The nasopharynx patients, you can imagine we're treating here. So from the back down, they start losing their hair a few weeks in. And then a lot of times our tonsil or they lose just the very corner behind their ear there. And it sometimes is alarming. I try to warn them. It's always hard to know up front who's always going to have that, but just be aware they do lose that corner. If we're treating around the eyes, they lose their eyebrows, or not typically eyelashes as much, but the eyebrows. And then usually the hair does grow back, but sometimes it's a different color, texture. It's not as thin, it's not as thick as it was. And then the scalp, if we're treating like skin cancers of the scalp, it's really hard for the hair to grow back because they're getting such a high dose to that area. Men can do a taper in the back for their hair. Women, it's a little harder when they lose that hair in the back, but usually if they have longer hair, it can cover it. All right, our first question here is, when should you start applying your calendula for your patients? 2 weeks before treatment, on the day 1 of treatment, day 14 of treatment, or there's no magic day, it's just whenever they feel symptoms.
So while we wait for some of these answers to come in, Joyce, if someone has a dressing on their neck, Mepitel or otherwise, how often would you change that during treatment?
It can't be on for treatment, so it has to be changed daily. The silver dressings are designed to be on for 12 to 24 hours, so we don't want them constantly taking it on and off. So we usually say 24 hours. If it's the weekend, our nurse practitioner tells them it can stay on for 2 days. Typically, there's enough exudate that I like them changing it daily. But because of you don't want that thick layer of dressing on there during treatment, they take it off before treatment. All right, most people got it right. So you want to start day 1. We're trying to prevent it from getting too red. We want to moisturize up front. Okay, constipation. So it's not that the radiation causes constipation. We're not anywhere near that body part, but a lot of our patients end up in the ER. They are just not going. They're not eating much. There's not much to come out, but something has to come out, even if they're not eating much. So there's a bunch of reasons. One of the best antiemetic medications, ondansetron, can cause constipation. If they're on opioids, that makes it worse. And they're dehydrated. They're not walking around as much. So plenty of water, walking around. Senna, we usually start with, and you could take a lot of it. People are like, oh, I take 1 or 2 at bedtime, but it can go up to 12 a day. If you're not going to take that much, you usually move on to Miralax or some kind of powder or fiber. Lactulose is a prescription. Most of these other things are over the counter. So that lactulose is every 4 hours or something until they go. Then if they're really not going, a lot of patients like, oh, I put an enema or suppository, which is fine. But if their white counts are low and you don't want any tears down there, introducing infection, we try to avoid those if we can. But you don't want to have your colon perf from not having a bowel movement. We try to tell them to go every few days, but many patients are like, oh, it's been a week. So stay on top of that. Could be dangerous. Fatigue, it's just part of treatment, definitely with chemo as well. It's the one thing that's systemic, so it's not the focal where we're treating. They're doing a lot of research, so I don't know if it's becoming clearer. Some people thought it was be like an overall histamine reaction in your system, but we're just really not sure why patients get so fatigued, besides that they're the physical part of it. But it helps to stay active rather than sleeping all the time. Patients always say, oh, I slept 12 hours on the weekend. I just couldn't get up. I don't think sleeping really, they don't wake up energized. They just wake up feeling tired as well. So patients sometimes say they just go home and take a little cat nap, especially if they're getting high dose, the stereotactic SBRT, they're getting high doses. They do get more tired faster. Walking's fine. You could just take walks. Some people really like working out. I'm going to bike here every day, which is fine. You just don't want to be burning more calories than you're putting in. The late term side effects. Yeah, we talked about the loss of saliva. Osteoradionecrosis is one of the more serious things. You have to be on a bunch of medications for a long period of time. Sometimes you actually need surgery to remove if it's your mandible. We've seen very serious surgeries, which we obviously try to avoid. We try to do the medication first, or people do hyperbaric oxygen, but just be aware that's one of the more damaging things. Hypothyroidism, yeah, we check the thyroid labs pretty closely every few months. Some people, if they've had neck surgery, they have a scar there and the lymph isn't draining as well, so they have edema. While their skin is tender, we try just to leave it alone, but then they can start doing gentle massages, and our speech and swallowing pathologists also help manage that. We have sometimes there are special physical therapists out in the community that help treat it as well. They can get secondary skin cancers or secondary cancers. The skin can actually get fibrotic over time. That's usually, like I said, more of a long term, but we try to have them do their neck stretches. Yoga is great for that because there's a lot of stretching. And then I think they put links to other things about the late term stuff.
So late side effects are such a complicated topic. We could discuss them for a long time. We have a few questions in the chat. I can read them out. So what is the role of dental extractions in head and neck radiation? And then there's a question about how does osteoradionecrosis present and when and what does it look like?
Yeah, so I was just putting in chat, I think every patient should get upfront dental evaluation prior to beginning head and neck radiation. And I know this sounds very simple. It is more challenging than it sounds, particularly in the US, where dental insurance and medical insurance are two separate insurances. And I would say here in San Diego, over 50% of my head and neck cancer patients don't have dental insurance. This is a huge challenge for patients. But whenever possible, I think it's really important to do a dental evaluation. If a patient has just poor dentition and needs dental extractions, we really prefer doing that prior to the onset of radiotherapy, because really post-radiation, my rule of thumb is that no dentist should go into somebody's mouth, particularly for any extractions, at minimum for 6 months post-radiation, ideally for at least a year. And even when you do extractions after a year, the dentist need to look at radiation treatment plans to see what that dental root got in terms of the dose of radiation and decide what the right course of treatment is going to be. So if you need a dental extraction after radiation, you may need prophylactic antibiotics before the extraction, and around the extraction, you may need hyperbaric oxygen, depending on what that dental root saw, really to allow for healing. Because one of those late complications that you can see after an extraction is osteoradionecrosis, where that site doesn't heal and you have exposed mandible for that patient, or exposed bone for that patient.
This is a perfect segue. I think Joyce's next slides are going to be talking about dental care.
Anything to add, Joyce, or shall we move on?
No, we can move on. The thyroid, the checking is for their life. Yeah, we check the thyroid because the radiation's so close. We try to avoid. You can usually see when we treat, we're avoiding the larynx and the thyroid, but it often does get hit. So that's forever. Yeah, and then I think we can get through the dental part because he just talked about that. Is that next?
We have a poll, which I will put up.
Oh, okay. Okay, yeah. What can cause constipation during treatment? A, dehydration. B, opioid use. C, ondansetron or Zofran. Or D, all of the above. Perfect. Yes, all of them contribute. Definitely opioid use is one of the bigger ones, but and the ondansetron. A lot of patients will stop taking it because it gets so bad, but all of the above can cause it. All right, I will try to get through some of the things faster. The dental care, yeah. So we have a dental oncology department. They try to see all of our patients before they start and help make the mouth guards that they wear. We briefly just talked about it. If the bone doesn't heal, they're at risk for osteoradionecrosis. Where a lot of people have metal fillings still, the radiation bounces off those fillings and causes the mucositis or sores, usually on the side of their tongue or on their cheek. So they have these in their mouth, and then the bite block moving their tongue out of the way. So this is what I'm saying, when they have a lot of things in their mouth and then they have to breathe through their nose with that mask on, can be difficult. But definitely we try to have them all seen up front because if they need those teeth pulled, we want it done before. You can do it after, but it has to be within like 6 to 8 weeks. Okay, next slide. They see our patients. They often prescribe Paradex, which is just a mouthwash. It's cleanser. Sometimes it burns, or all mint. Even the toothpaste can burn, so we tell them they can back off from that. Some people buy the kids like fruit flavored toothpaste if they find that more tolerable. The salt and soda rinses are very important for the dental care. Some people have flaps and all kind of folds in their skin, so we do try to have them do a water pick or really flossing. Same thing, they can back off on flossing if it hurts a lot, but afterwards they really need to take good care of their mouths. Once their mouth's healed, we have them get a good dental cleaning, and then they're supposed to go every 3 to 4 months. Like you said, the US has terrible dental. They only want to cover twice a year, if that. So if we're telling them to go more often, it's often out of pocket. Talked about the extractions or implants. You don't want those done into the bone. They use high fluoride toothpaste for life, and that's something that they paint on or brush on, and you leave it on for 10 minutes. So we'll tell them put it on before your shower. So while you're showering, it's just sitting on there. And then you want to take that off because their lack of saliva makes them prone to cavities forever. Communicating with the community dentist, they often call and say, I need to do this filling or extra root canal, which are safe. The thing we don't want them doing is the implants or the removing the teeth. So they will send in a form on what tooth it is, and our physicists have to go and see how much dose was given to that area before we want them to do anything. So we're going into some body parts, what makes it different. The nasopharynx, besides doing the oral rinses, we have them rinse their sinuses with Neomed, makes a saline spray bottle. Just goes through the instructions here. You want to use distilled water or boiled water that's cooled down. You don't want to introduce any kind of microbes in there since you're so close to your brain. Or you don't want infections in there. You can microwave pulse it, but just be really careful with microwaves because it can heat up things. Do it over the sink. You want to go in one side, it comes out the other side, do the other one. Spit out any solutions in your throat. You want to blow their nose gently. You use the entire bottle each time, and some patients do it multiple times a day if they're feeling really dry. And this is especially if they've had sinus surgery. Usually if they've had surgery before, the surgeon already has them doing this. So when they start radiation, it's already on their schedule, but it will get more dry. And then there's a link, because it is confusing, of actually a YouTube video showing how to do this, because I think it's a little uncomfortable having that feeling of kind of like you're drowning, having all this fluid in your sinuses. The other thing people can do, you could do the next slide, or sinupulse, which is like a water pick for your nose, where it actually puts water up there, or the neti pot. Same thing, you pour it in one side, out the other. If they're usually they'll have a little bit of blood coming out when they blow their nose. If it's actually running, then we need to have that stop and they need to go to the ER. But typically we just start with Aquaphor or Vaseline in there, or there's actually spray like lubricating gel that you can spray up into the sinuses. It is going to be dry for life, and they lose sometimes the hair that kind of protects you from traps all the things you're breathing in, the pollutants and stuff. They're just more prone to infections. Again, the nasopharynx, you want to make sure they know about losing the hair on the back of their scalp. And sometimes if they're not rinsing well enough, they do have a scent coming out of their sinuses, and the team will tell them to do a little drop of baby shampoo in the spray bottle to help clean it out. If it's worse than that, sometimes I think they actually put like Bactroban or something inside there. Like I said, it may require more of an antibiotic. And usually the family members tell them that they notice the smell first, because the patient often doesn't notice it. Periorbital, if we're treating around the eye, it'll get eye dryness or tearing. So sometimes patients, it's counterintuitive, but it's tearing because it's dry. So it seems like it's really wet all the time. There's different eye drops. We recommend Refresh or Sustain, but we don't want to use the ones that are Visine or that are for the redness. We're trying to moisturize it. If they can't close their eye all the way, sometimes they've had surgery or the nerves are affected. So they actually put a lubricant in their eye, especially at night, because that's when you don't want corneal abrasions or dryness causing tears in there. They have to wear like a bubble over it if they can't close it completely, just because you really want to keep that moisture, an eye patch. And then usually the surgeons at the time will put like a gold weighted chain. And if it's not working completely, they fix it after they're done with radiation. Like I said, that's usually when they have to sacrifice the facial, some of the nerves to the face that prevent that eye from closing. For the larynx, obviously we're treating the voice box, so they do have voice changes. Obviously, sometimes they start with that, so they sound hoarse or whispered or very high pitched. And unfortunately, there's a lot of singers, and they're obviously very worried about their voice, or they are public speakers. So we try to give them vocal rest and try to tell them not to talk too much during treatment or after, just to prevent that, because there's a lot of swelling down there. They can be fixed or not able to close, and that's when they run the risk of the aspiration. And that's when the speech and swallowing therapists, like I said, I know not everyone has those available, but I think even the doctors can look down with an endoscope and make sure that those vocal cords are closing. Sometimes this ENTs will put injections in there to help those vocal cords close completely so they can swallow better. The patients who've had a total laryngectomy, we usually try to wait a few weeks before we start the treatment, usually 6 weeks. Sometimes patients, the tumor is affecting their breathing currently before they even start, and they have to do like an awake or emergent one. But typically, these are when we know up front that they need this removed. Obviously, they're not able to speak usually. A lot of people use their phone to do text to communicate, or they have those electrolarynx. A lot of patients don't like those. They sound very robotic. But luckily these days now they can do this TEP where they put a little puncture between the trachea and esophagus, and it helps them vocalize. Otherwise, make sure you have something for the patient to write on. This boogie board is just a brand where it's like not an extra sketch, but you write and then it can erase quickly. So you don't have to keep using paper. The skin reaction is often worse if they're wearing a trach collar. It acts as a bolus, which means just the skin reaction gets worse under there. It's often after they're done, so we want to keep the moisturizer going or putting that Mepilex light or some kind of barrier under the trach to prevent that friction from rubbing. A lot of patients can't handle their secretions, especially they have to lie flat during the treatment. So sometimes we literally bring the little portable suction machine into the treatment vault and suction them before or even after to help them get through. Many of them have feeding tubes due to there's just a larger field oftentimes when they've had total laryngectomy, because that means it usually involved their other areas, the trachea or out into the neck. And then, yeah, the psychosocial part can be obviously very important for these patients, a huge component of their therapy. Go to the next slide. A lot of the nursing care is providing that emotional support and encouragement, not only for them, but for their caregivers, which can obviously run the gamut of partners, children, parents. There's a lot of stress that comes in the relationship. The patient's not eating, the family member they have so much food in the house. They keep buying more and more things they think the patient might like. They end up eating it all. So there's a stressful dynamic between them. So I'm a little bit of a marriage counselor. I often try to take the family member or caregiver outside the room, give them their own support, say, I understand this is hard for you too. And they really do appreciate just hearing that. I know it's hard for you too. It's obviously their loved one going through this, and we're not taking that away from them, but understanding that this is affecting the whole family. Especially when like food is such a huge part of our social lives, eating out takes them so much longer than a normal person's done with a meal. They're an hour to drink an Ensure, like at home. It's just, it takes me so long just to sip this down. So the whole social aspect of eating is really affected by this. Many patients live alone. They don't have any support. We treat patients from our veterans that are often a very difficult population. We also treat our community hospital, which is our county hospital, which is very indigent people. They often don't have a lot of support. So our social workers are very key in helping getting these patients through. Luckily, we have a Lyft or Uber program where if they live within a certain range of the hospital, we provide rides every day. They can get them gas cards if they do live further away. We have an actual housing unit in our city where, depending on financially, that's either free or they can pay a certain amount to stay at it's like a hotel, but it has community kitchen. So they have their own bedroom, but the kitchen and living space is shared. But anyway, it depends on obviously what your hospitals provide, but we can have vouchers, taxi vouchers, things like that. So we try to help our patients to get to treatment every day, because obviously when they're missing treatment, it's not helpful. And then we do have a support group that our social worker runs once a month that's on Zoom. They sometimes have guest speakers, which is either the nutritionist and it's a mix of current patients, former patients, and it's good to have the former patients, obviously, because they can provide a lot more support or feedback on things that they went through. Oh, and then I want to talk about how the tumors for head and neck are visible. Sometimes it's growing out of their neck. The dressings that they have on now, like if a breast patient has wound care, it's often covered up. But for the head and neck, like I said, we can't put tape on. We have to have these huge dressings. Sometimes it goes around their head this way because it's on the side of their face, which you can't really put a dressing there. Sometimes they're malodorous. If the tumor is like fungating, there's just a lot of psychosocial issues with it being visible. You're visibly sick to people. So we want to, sometimes I tell them to wear like a scarf or something, pretend like they have an ascot on or something to help with that. But it is more visible than other cancers. And then this is just what we provide, the head and neck starter kit and what we do for our patients here. I know, like I said, this is not available for everyone, but we have the teaching materials, one just on the side effects and like about the schedule, and then a whole book just on nutrition, because we keep saying how important that is. It has recipes, what to do for certain side effects, a whole list of all those supplements that are available. And I tell patients up front not to go out and buy a case of any of those supplements until they try it. They all have different flavors, textures. Some patients just prefer one over the other. So wait until you get a sample of a few and see which ones you like. We treat a wide variety of cultures, so make sure you have some of your educational materials in different languages. It's been much easier now having translators that we can use Zoom than where it had to be in person, where you had to schedule ahead of time. Just make sure you're able to cover not just the educational material, but sometimes cultures just have different ways of dealing with food and things like that. We provide the lotion. We actually provide all of the skincare. Those dressings, a piece of Mepitel is like $15. It's crazy. If you go on Amazon, you can buy them, but you're going to go broke. So luckily here we're able to provide all of the skincare materials, but I know that's not available to everyone. Some people just give out Aquaphor and that's what they get. And then they go to like wound care, or if they have a dermatologist, they see them. But like we said, we have to really deal with the skin. I also give them like a checklist. I didn't include it here, but it just has a list of all the medications. Everything has a brand name, a generic name. Everyone gets confused. We try to make it easy with a list of all those, and then photos of the actual product so that when they go to the store, they know what it looks like. And just to help them out a little bit. And it also has, the pictures that help. Providing phone numbers for your clinic, for your nurse's station, the after hours. A lot of things happen on the weekend or at night, and they send these My Chart messages electronically. We don't work on the weekend, so I feel bad when they're sending these emergent messages that they don't get. So there's always a resident on call that they start with to call them back and talk about any issues they're having. Otherwise, they just go to the emergency room. We also have weekly multidisciplinary rounds, which is very helpful, which includes our attending physicians, the nurse practitioners from both the chemo side and the radiation side, the medical oncology coordinators, so help us coordinating, because usually chemo and radiation start on the same day, so we try to get everyone scheduled accordingly. The social workers there, because I said they play such an important role with getting rides and housing for our patients. Our dietitian is there, the speech and language pathologist, so the doctor can say up front, we know I really want you to follow this patient or see them ahead of time. The authorization coordinator, if insurance isn't covering this, we're not starting at all. It's important to have that aspect done before we even start the treatment. And then the attendings practice coordinators to do all the scheduling and behind the scenes work for all of these patients. And like I said, we meet once a week and talk about the current patients, so if they have any needs, and then anyone upcoming that has to deal with, that we want to address any of these issues with. So yeah, we're very fortunate to have this. It does help a lot. The take-home points, just remember radiation is very focal. So you want to think about your basic anatomy. If it's going to your sinuses, what's going to happen? If it's going to your mouth, what's going to happen? If it's your tongue, we're seeing a lot of younger patients getting oral tongue cancer. So it really just depends on where the beam is going. And just be aware, a lot of times the machine moves around the patient, so the beams are coming from the back. So make sure they're putting their lotion on the back of their neck as well, things like that. And then, we can't stress enough how much nutrition is a huge key to their success. It just helps them heal, makes them feel better, gets them through this. And then just keep learning. There's a lot of research going on out there. I don't know if you have available, there's an oncology nursing society here. I don't know what's available in your countries, but there's resources out there if you ever have questions about how to help take care of these patients.
I just want to say how important partners nurses are in taking care of head and neck cancer patients. I think every oncologist will tell you that without a very engaged nurse partner on your team, you really can't take care of these patients. So I really want to recognize that and thank everybody.